Hello friend, welcome to my channel 5-Minute Pediatric. Few days back I have posted question on Facebook. The question was at 4 weeks of age a male child comes with non-bilious vomiting and X-ray abdomen showing this. So what will be the probable diagnosis and how will you confirm this and what is the confirmation criteria for this condition? So the diagnosis is congenital hypertrophic pyloric stenosis. ये कंडीशन है ऐसा है जो कि कॉमन होगा मेल चाइल्ड में. यदि कोई मेल चाइल्ड नॉन बिलियस वोमिटिंग के साथ 4th वीक 5th वीक में राउंड आता है तो वी शुड सस्पेक्ट दिस कंडीशन. ऑल्सो कॉमन जो कि ब्लड ग्रुप है O और B ब्लड ग्रुप में कॉमन होगा. इट हैज़ बीन ऑल्सो फाउंड दैट इफ़ अ न्यूबॉर्न बेबी टुक इरेथ्रोमाइसिन इन फर्स्ट वीक ऑफ लाइफ they may also develop congenital hypertrophic pyloric stenosis. There are several studies showing that if a mother who took erythromycin in first trimester, their child may have congenital hypertrophic stenosis. Okay, this condition is also associated with TEF or some hypoplasia or agenesis of the inferior frenulum. So the clinical manifestation are typical. The child may have non-bilious projectile vomiting, but initially the child do not have projectile vomiting, only present with non-bilious vomiting. It may be intermittent or may persist. Hyperbilirubinemia is common association. Okay. So if we go for the ABG finding, what you will get? As the child is vomiting continuously, there is a loss of hydrogen ion, chloride ion. So there is a hypochloremic metabolic alkalosis. This question is frequently asked in most of the PG examination. So how will you diagnose it? So traditionally it is diagnosed by palpating the pyloric mass. So you can feel the olive mass after episode of vomiting, and after feeding you may see the peristaltic wave moving from left to right across the abdomen. Okay, so the confirmation is made by ultrasonography. So the criteria for diagnosis, we have pyloric thickness is about 4 mm, pyloric length 16 mm and pyloric diameter 12 mm. So this is the diagnostic criteria. If you get this, then the child is having congenital hypertrophic pyloric stenosis. If you go for contrast study, you may get numerous sign like string sign where you can get elongated pyloric canal. You may get shoulder sign where the bulge of pyloric muscles into the antrum, and you may find double track sign. There is parallel stick of barium seen in the narrowed canal. So the common differential are GERD or pyloric canal duplication or duodenal stenosis proximal to ampulla of Vater. So you may confused with this condition, as you may get repeated vomiting in the form of projectile vomiting, and vomiting is non-bilious. Surgery is the treatment of choice. So surgery, we have Ramstead pyloromyotomy, and if the child is not good candidate for surgery, we can give atropine. There are several studies where atropine is found to be having very good result in hypertrophic pyloric stenosis. Hope you enjoyed this video. Kindly like, subscribe and follow my channel. I have already made video related to peristaltic waves, and you can also go through the X-ray. Thanks.